21 million people in the United States in any given year have addiction. Substance use disorders and addiction are devastating, as you know, right? They steal people from us. Before they steal our people from us, it becomes very painful.
I met the most amazing woman who was the keynote speaker at a conference on addiction, mental health, and overdose. Her name was Dr. Nzinga Harrison, and I learned so much from her about the disease of addiction, from the fact that it's 30 to 60% hereditary, to how both adverse childhood experiences and positive ones can play a role in whether or not someone turns to substances to cope.
What you can look for in your kids: depression is a risk factor for addiction. Anxiety is a risk factor for addiction. Not having a friend group, not belonging, is a risk factor for addiction. Your family history biologically is a risk factor for addiction.
Dr. Harrison was also featured in the powerful documentary, Tipping the Pain Scale. I recommend you see it. I'm so excited to have her as a guest on my podcast, and I know you'll learn a lot from her as well. And Nzinga, thank you so much for coming on the podcast. I was so excited to have you because I met you a couple of months ago, and I was really struck just by how welcoming you were. You have so many qualifications behind your name, and I know a lot of education, but you really were down to earth. And I think maybe to relate to people suffering from substance use disorder, you have to be, right?
Yeah, thank you so much for saying that, Angela. So first of all, I'm a Midwest Indiana born and raised girl, right? So down to earth is how we do it. But I also just think being accessible and warm is one of the most impactful things we can do for people. So it's really important to me. So thank you.
Now, I know you're a doctor of psychiatry and also qualified in addiction medicine. How did you happen to choose that career path?
You know, I decided really young to be a doctor and a teacher. And I didn't have doctors in my family, so that kind of came from having pediatricians. My mom was a teacher, so that made sense. And so I thought that I would be a pediatrician, but importantly, I mentioned that I grew up in Indianapolis to be specific, and my dad was founder and commander of the Black Panther militia when I was growing up. And so I was raised an activist, I was raised an advocate. We were kind of raised with the value set and belief set that you raise your voice on behalf of people who are being mistreated. And so when I went to medical school, you know, you have to cycle through all of the major systems. So you do OB-GYN, pediatrics, emergency medicine, surgery, psychiatry. And when I did my psychiatry rotation, I really felt myself thrust into the biology of behavior and the physiology of feelings. It was the specialty that gave you the most time to build relationship with your patients. But then I also just saw how so much stigma inside the medical infrastructure and outside the infrastructure really just created a community of people who were being mistreated. And so psychiatry tapped my activist bone, it tapped my relationship bone, it tapped my scientist doctor bone. I saw so much opportunity to teach like other doctors that mental health conditions, substance use disorders included, are chronic medical conditions. And so I just say it was the medical specialty dress that fit the best.
And most doctors get very, very little training in addiction, maybe a day in medical school, right?
If even, so that's changing now, which is great. And there's legislation even to help change that. There's a MATE bill on Congress to help increase addiction treatment education. But yeah, psychiatry was 6 weeks and none of my psychiatry rotation was focused on addictions. So I did extra electives in medical school, but if you didn't choose to do those electives, you wouldn't have learned about it.
I also think that just as we screen often when you see your primary care doctor or your first touch point with whoever you see in the medical field, we screen for abuse often. We screen, but we don't screen for addiction, which I find so interesting.
Don't you find it so interesting, Angela? Because 21 million people in the United States in any given year have addiction? And I think part of that, I feel like I paid you to ask that question. I think part of the reason we don't do the universal screening, one, you put your finger on it, we're not learning about it in medical school. But two, people have this concept of addiction that really represents the most severe form of illness,
sure.
right?
Sure. And there's all kinds of, it's like a scale, right?
There's a scale. There's mild, moderate, severe, just like there's mild, moderate, severe high blood pressure, mild, moderate, severe asthma, mild, moderate, severe diabetes. And like all of those, if you can catch it when it's mild, that's why we screen for things. Breast cancer, we don't call it mild, moderate, severe. We call it stage 1, 2, 3, 4, right? But the reason we screen is so that we can catch it in stage 1, because that's so much easier to intervene than stage 4. So if we could move to universal screening by primary care docs for addiction, we would have so much more opportunity to intervene early for people and families.
Yeah, I wonder what it will take for something like that to happen.
It shouldn't be that hard. So I recommend this scale. It's called the CAGE, CAGE. So for all of your listeners, you can screen yourself right now. You can screen anybody in your life that you're concerned about. It's called the CAGE, CAGE. It's 4 questions. And if you answer yes on any one of these 4 questions, that predicts with 77% accuracy that you may have a substance use disorder. Now, it may be mild, moderate, or severe, right? But 77% chance is enough reason to go get a full evaluation. So the first question is, have you ever thought you should cut back on whatever the substance is? That's the C. The A is, have people in your life been annoyed by the way you use this substance? So we can talk about cigarettes, right? Like, is your spouse constantly asking you not to smoke in the house and you try not to smoke in the house, but you sneak and smoke in the house, and then you argue about it? That would be a yes for A, annoyed. G is guilty. Have you ever felt guilty about the way you use this substance? So I didn't mean to drink that much. I said I wasn't going to drink today. I said I wasn't going to take more pain pills, but then I took more pain pills, right? Like whatever the substance. I said I was only going to smoke 2 cigarettes. I said I'm only going to smoke at parties. I'm smoking on my porch. So have you ever felt guilty about the way you were using that substance? And then E is for eye opener. So eye opener initially was meant for alcohol, like you have to drink first thing in the morning so you don't.
I learned that. I just learned that with a previous podcast guest who's a doctor in addiction studies. I was like, eye opener like coffee, and she's like, no.
Yeah,
that's like a drink first thing in the morning. Because we were talking about women and alcohol because it's so prevalent now. Yeah.
Yep. But even beyond alcohol, the way I use eye opener for people when it's a substance other than alcohol or opioids, both of those you'll get withdrawal, and cigarettes, but is like when you wake up in the morning, is that substance on your mind when you open your eyes? 1, CAGE, cut back, annoyed, guilty, eye opener. An answer of 1 predicts likelihood of a substance use disorder. A score of 1 is probably going to be a mild substance use disorder, like let's catch it while it's stage 1, right? A score of 4 is going to be further along the spectrum, let's intervene to help out. But that's how easy it could be, Angela. Every single PCP, every single hospital doc, every single ER doc could be putting those 4 questions, but stigma prevents us from doing that.
Right, stigma because society in general still sees addiction as a moral failing or a character weakness.
There it is.
And I learned
and that kills people, Angela.
Yes, the stigma, right?
The stigma.
And I learned from your talk that addiction, I have asthma. And so I loved it that you compared it when I listened to you speak, the hereditary factor of addiction, 30 to 60% hereditary, just like my asthma, right?
Just like your asthma, coded for in your DNA.
So why is it, do you think it's so hard for people to accept that? I mean, to accept that addiction is a disease of the brain, to accept it's a disease like diabetes or heart disease that's hereditary. Why is it so hard?
I think because the symptoms of addiction are feelings and
Social.
thoughts and
Mhm.
behaviors. And in this country, we conceptualize the way you think, the way you feel, the way you interact with others as who you are, right? It's hard to conceptualize those as symptoms. And so it's substance use disorders and addiction are devastating, as you know, right? They steal people from us. Before they steal our people from us, it becomes very painful. But isn't the same true for Alzheimer's? Isn't the same true for
Yes.
cancer, right? Like
Yes.
the it just makes it so painful to be with your loved one as that disease progresses and then that disease steals you from us. But it's much easier for me to see weight loss as a symptom than it is to see anger as a symptom. Or it's much easier for me to see like asthma. I can put the pulse ox on and it'll give me a number. And it really tells me you're not just making a choice to do that because you can't control that O2 saturation, that number, right? Or
Right.
you can't control that blood pressure. I know you're not doing it. And so it just makes it easier for people to conceptualize that some process is going on in the body that you don't control. We think we control our thoughts, our feelings, the way we interact with people. But that was one of the things that was so fascinating to me in medical school, was just how much of that is biological.
Yeah, having lost my daughter and being a mom, I think I go over every little detail of her life since she was born. Like, what were the indicators, that this was going to happen to her, that she was going to start using and become addicted and die because of fentanyl. But I think back, like she was super intelligent, super gifted. She was also very dramatic and emotional. And I I think before actual addiction to substances, well, sugar is a substance, I felt like she had an addiction to like carbs and sugar.
Mm-hmm.
And I don't know if there's a correlation. I'm asking you because you're the expert. If you see something in your child that would indicate, hey, they could have these genes or they could be set up for this type of thing.
There's absolutely a correlation. So I'm going to answer your question, but I'm going to take one step back before I do. This is a neurobiology lesson, right? You've heard of the neurotransmitter dopamine. So we call it neurotransmitter because it transmits messages in your neurological system between your brain and your spine, the rest of your body. Dopamine's message is, you need this to survive. Like evolutionarily, that's what dopamine tells us. This thing is more important than anything else. You need it for you to survive. You need it for the species to survive. And the natural things that cause a dopamine signal are food, sugar, water, sex, because species can't go on if we don't reproduce, right? Nurturing. So two things. The reason I teach so much about 40 to 60% of our risk for developing addiction being coded in our DNA is because that gives us an opportunity to practice prevention. I can look, when a doctor asks you about what runs in your family, we're looking for that genetic contribution. So if anybody in your family has been addicted to anything, your risk is higher, your children's risk is higher. So I have a very dense history of substance use disorder, depression, and anxiety also in my family. So that gives me the opportunity to practice prevention with my kids. My kids can tell you already, like I laugh because I heard my 15-year-old son talking on the phone to one of his friends. And he was like, yeah, man, the way my DNA is set up, I can't start smoking weed because I might get addicted. And I was like, yes, an ounce of prevention. To your point, Angela, what you can look for in your kids, depression is a risk factor for addiction. Anxiety is a risk factor for addiction. Not having a friend group, not belonging, is a risk factor for addiction. Your family history biologically is a risk factor for addiction. addictive type behaviors around anything, sugar, thrill seeking, all of that's running through dopamine. And so it's giving us an idea of how your dopamine system functions. And we can use that as early insights so that we can practice prevention.
I always say that my daughter was a risk taker. She was on the balance beam, in front of a huge audience. She did hurdles. I mean, so I think, I saw that risk taking behavior. I saw that sort of addictive behavior even as a kid. I never thought it was going to lead because she also knew the way drugs had harmed her family. Mm-hmm. So I thought I could prevent or inoculate her in that way by, hey, here's some things that have happened in your family because of drugs. Mm-hmm. But I think the other thing that is so interesting about, we talk about our children and this, our adverse childhood experiences. Now, I probably had I don't know if I had every adverse childhood. I had a lot of adverse childhood experiences, but I'm not addicted to anything, and I don't know how many of the positive, maybe you could touch on that a little bit, how that comes into play as well.
Yeah, and I want to widen the definition of addiction here. I tend to use addiction to mean anything I continue doing despite negative consequences outweighing positive consequences, right? You see the negative consequences. And so we don't tend to think about, and so I had a podcast called In Recovery. You can find it anywhere you listen to podcasts, is what they say. In Recovery was about all things addiction. And so we talked about exercise, because you can use exercise in a way that causes negative consequences, but we value exercise so positively in this country that people wouldn't think about as addiction. Work is another addiction that a lot of people have, right?
And workaholics, right?
Yeah, we'll think to ourselves, I'm not addicted to anything, but there are behaviors that we have in our lives that dopamine pathway is giving us some signal about our risk. But to your point about these adverse childhood experiences, there are 10, and the more you have actually predicts not just mental health conditions later in life, but physical health conditions also. So stroke, cancer, premature death. I did mean premature death, but I meant premature birth is what I meant to say. Asthma, high cholesterol, stroke, all of these are predicted by the ACEs, right? Because our physiology, brain, and body is one. It doesn't mean, just like your whole family has addiction, doesn't mean you'll have addiction. 40 to 60% chance. All of these ACEs doesn't mean you will develop any of those conditions later in life. It means the chance that you will develop them is higher. And so whenever I talk about ACEs, I always talk about, and so what can we do to mitigate that risk? What can we do to mitigate that biological risk? What can we do to mitigate the risk of adverse childhood experiences? And the answer are positive childhood experiences. Have you heard of the pieces?
From you. I heard them from you.
Oh, you heard it from me.
Yeah.
I'm being true to myself, because I'm like, I will never talk about ACEs without talking about pieces, right? So we need to know about ACEs so that we can try to keep that score 0. We need to know about pieces because we can't always control ACEs. Things are going to happen. Pieces are positive childhood experiences. There are 7 of them. And the more you have, the more they decrease the risk of those ACEs, the more they decrease the risk of that biological risk loading. And so we can't say, because of your family history, this is going to happen to you. What we can say, because of your family history, we know you're at greater risk. So let's try to do everything to minimize that risk.
Yeah. So do you think that most parents and caretakers are aware of any of that?
Right. Never heard of ACEs, never heard of pieces. And we should certainly, the way we try to get every parent the support of a pediatrician. I feel deeply ACEs and pieces should be part of the guidance that pediatricians are giving. We try to get every kid access to school. I feel deeply ACEs and pieces should be part of the fundamental curriculum that schools are required to teach. Yeah. There's power in pieces.
What do you think, have you noticed in your practice that I've always heard the solution to addiction is connection.
Ooh.
Do you think that there is one, I know there are a lot of different pathways, right? And I know at Eleanor, you allow a lot of different ways for people to find recovery. Have you found one thing is the most successful, or does it always depend on the individual?
Connection is always the common thread. Connection alone is likely not enough. Anything else without connection is likely not enough. So you're right. At Eleanor Health, where I'm co-founder and chief medical officer, we take care of people who have been affected by addiction. And our belief is that there are an infinite number of pathways to addiction. So there have to be an infinite number of pathways out of addiction. But the common thread where all of those pathways branch from is that connection. So remember when I gave that neurobiology lesson on dopamine, and I said one of the natural signals that causes dopamine is nurturing. That's connection. Like we are neurobiologically wired to need connection. And when that connection is severed, and a lot of times it's a severing of that connection that then makes a risk for addiction turn into addiction. Then it's stigma and severing of connection that drives the addiction to be worse and worse and worse and worse. When we're disconnected, we die. When we're disconnected, we die.
I think that's where I felt as a parent, I got bad advice to do this tough love stuff when my daughter started using to cut off, like, oh, you're not going to get to do this, or you're not going to. I think that severs the connection. And I think as a society too, what we punish people with addiction, right? And we cut them off from society. I mean, I'm talking about like my own little case, but then like all of society. That's what we do. I was so glad in the last couple of years of her life, last few years, I just approached her with love because I realized none of that tough love stuff worked. In fact, I think it made things worse. And it was really hard for me to do, but I was just trying to do what all these experts were telling me to do to try to get my daughter on the right course. Instead, she went completely on the wrong course, and maybe partly because of it.
Yeah, and it's so hard, right? Because so many experts are out there giving this tough love. Like, love doesn't hurt. Love is not tough, right? Love is warm and love is soft. And that's not to mean that they're to have a complete absence of boundaries. So harm reduction here is what we're talking about. Harm reduction is compassionate boundaries, but it says, even though you're using drugs or even though you have an addiction to whatever, I don't want you to die. And we just established that when we sever people's connections, they die. So if we don't want people to die, we don't sever the connections. That doesn't mean your daughter lives in your house if that's creating psychological or physical lack of safety. That means I can't have you live here, but I'm always your mom. We can always meet here. I will always pick up the phone for you. Let me find a place where you can live, where it will be safe for both of us, right? We set the same boundary. You can't live in my house. We didn't give it tough love.
Anger, right? No anger involved.
Yeah, because what I tell folks when I'm helping family members and people affected by addiction is, you're not angry at your loved one. You're angry at the disease of addiction. And the more we can put you and your loved one on the same side and addiction over there, instead of what it usually is, which is addiction in between you and your loved one. So then you point your anger at addiction, it goes straight through to your loved one. The two of us on this side, addiction over there, pointing our anger at that, you start separating those symptoms from your person, and it makes it easier. But the other thing is, I absolutely love this company called WeTheVillage.co, started by a woman, Jane Mackey, whose partner was in active addiction. And as she was trying to navigate the same way you were, right? Like getting all these tough love and got to hit rock bottom. For too many people, rock bottom is dead, right? Like
it's death. There's no such thing as rock bottom in today's world with fentanyl out there.
Yeah, like, no, we cannot take the risk of this, right? She started We the Village, and it's based in this method called the CRAFT method, but it basically teaches members of the support system, so not the person with the addiction, how to set compassionate boundaries, how to navigate their own journey of recovery, how to love your person in active addiction, not tough love your person in active addiction, And it's so interesting. They did a study and it showed that 65% of loved ones that went through their program, their person went into treatment.
Wow.
And 6 months later, we're still in recovery.
So really all you can do as someone who has a child or a spouse is to work on yourself and your own responses, right? I mean, I always say I wasn't a puppet master of my daughter. I think people think parents, and you're a mom, especially mothers, have all control.
Yeah. And we do not.
Yes, we do not. But I love that concept that you just work on yourself and the correct ways to approach this disease.
But I always try to take it out of addiction into a physical health condition that people can better understand. When your person has terminal cancer and cancer is ravaging them, it's devastating. You need your own support. You need someone to support you so that you can support your loved one, right? This is exactly the same.
But when it comes to society as a whole, the solution is oftentimes jail or prison. And I know, at least in my state, they're not getting treatment in prison. Maybe they get it, the last 6 months before that. It doesn't make any sense to me that you would hold someone, lock them up basically, and then not give them any way to recover. And we know there's drugs in our prisons. And so is anyone, this is where I feel like these societal shifts can't come soon enough. And I don't see them coming at all. Do you have hope in that area?
Yeah, I agree with you. They can't come soon enough, but I promise you they are coming slowly but surely. We have to stop locking people up, period. Like, getting locked up is one of the most traumatic things that can happen. Trauma directly drives addiction, right? So we're not helping people. And to your point, most folks are not even getting addiction treatment in an incarcerated setting. But even if you are, like, think about living in a cage. Think about your dopamine system. Think about your trauma reaction. Think about being in a cage as being disconnected, right? Like, it's isolation. Physiologically, like, there is nothing about an incarcerated setting that is helping us get healthier. That said, there is a ton of work going on behalf of people with substance use disorders to decriminalize it. And actually, like, I can legitimately be hopeful in this way because I'm co-founder of this national advocacy organization called Physicians for Criminal Justice Reform. And we have a task force dedicated to correctional healthcare. And we have a task force dedicated to decriminalizing mental health and addictive diseases. But to your point, Angela, the work is slow. And I think it has to start with just changing this concept that people with addiction are bad people.
Right.
It has to stop. Like, people with addiction are not bad people. People with addiction are people with a bad illness.
Right. I heard a sheriff's deputy I was on a panel with once said, I wish we could just take all of these nursing homes that are empty right now, because we had several in our state, and we could set them up as treatment centers, and you'd be sentenced to this treatment center, but you get treatment. Maybe you couldn't leave for 18 months. I don't know why. I mean, wouldn't it be less expensive?
It would be less expensive. You would have less recidivism, so people would go back to jail less. You would have fewer suicides, like the risk of completed suicide after jail is higher than before jail. You would have less relapse of substance use disorders. Like, let's not make this a wish we could. Like, what do we need to do so we can do that?
Right. I would love to see all of these things happen. I can't even get involuntary commitments taken out of the court system in my state. I don't think they belong. I don't think you should have to pay a lot of money to go and get someone help who, is going to die.
Yeah. Or fentanyl strips being a felony to have fentanyl strips. Can people live?
Right.
Can you test your drugs and to make sure there's no fentanyl in there? Just having a fentanyl strip equals to jail.
Right. Until we can get you help, until you're ready for help,
Yeah.
Let's talk about relapse for a moment, because that's another thing. I've seen the stigma surrounding people who relapse, and I've seen it at all different levels. I'm a journalist, so I was working on a news story, and I was going to feature this man who was in recovery from heroin addiction, had a wife who was a nurse, 2 beautiful children, and was going to one of these mega churches. And it really helped him. And we were going to go get some video of him in church. And between the time I interviewed him and the time we were going to do that, he relapsed. And so the pastor of that church called me up and said, you can't come get video of him now because he relapsed. And I thought, well, why not? I mean, to me, like that stigma and all things at church, that stigma of relapse is like you failed. You're no longer in recovery. That was the message I was getting.
Yeah. So I want to make, if you'll allow me to, Angela, just a little tweak on your language, because I think language matters so much. Illness is relapse, not people. But this is the way we talk about addiction, right? Like we say the person relapsed, but think about, I always give the comparison to a person with cancer. When the cancer comes back, we don't say that person relapsed, because we're not giving them the responsibility or the blame. We're giving it to cancer.
No, you're 100% true. I mean, I really appreciate you pointing that out, because I think about that a lot with people with disabilities, that kind of thing, but not so much as I was telling you that story. You're right.
It's subtle, but it's one of the ways, language is one of the ways we train ourselves into beliefs. And so when this person experienced a relapse of his illness, because I agree with you so much, why does that have to be a secret? Why does that mean he can no longer come, like his story is no longer important? He's not worthy. Yeah, he failed. He's not worthy to have his story told. These are all of the ways we drive that stigma. If we can start, I try to tell people, like, if you're going to say a sentence about addiction, replace the word addiction with cancer and see if you would still say that sentence. So would that pastor have called you up and said, this woman had a relapse of her breast cancer, she can no longer come on your show? No, he would have said, this woman had a relapse of her breast cancer. And when she came on your show, that would have been an even bigger outpouring of support and connection for her. If we can get to that same, because what it is, addiction is a chronic, relapsing, remitting illness, just like high blood pressure, just like diabetes, just like asthma, just like cancer. And what we do in medicine is figure out what are the things that drive relapse risk so that we can try to look for them and try to prevent them. So if you have cancer, we're going to give you your course of chemo and radiation. Let's talk about breast cancer specifically. We're going to try to make sure you're doing those monthly breast exams. We're going to move up your mammogram from every year to every 6 months. We're going to put you on tamoxifen if that's appropriate, right? Like we're thinking about it biologically. We're going to ask you to keep your stress low if that's possible. We're going to try to make sure you're getting good nutrition and eating healthy. We're kind of trying to manage the rest of your health so that your immune system is in top shape. All of those things that we know drive risk of making that, we're going to say, please don't smoke, right? All of those things that we know that drive risk for relapse of breast cancer. We tell you about it. We're checking in on it every month, every few months. We're doing surveillance to make sure it's not coming. Why don't we do this for addiction? We know the things that drive relapse of addiction. So can we be giving education to what those things are? Can we be putting supports in place to try to prevent those things? Can we be putting surveillance in place while people are using their lives? Here are some ways you can check to see if the risk for addiction is coming so that we try to prevent it. But just like we can't prevent all relapse of diabetes, just like we can't prevent all relapse of asthma, just like we cannot prevent all relapse of cancer, when it happens, we need to stand in active support position, not in shaming, you no longer get to tell your story position.
Right. I think that happens to so many people, or their families give up on them, or yeah. What is coming down the pike that excites you about in addiction studies or the addiction medicine field? Are there some new things that we're learning, or are there new medications? Are there new things about the brain? I wish we'd get to the point where we could target these areas of the brain. I don't know how far away we are from that kind of thing.
Yeah. So I always like to talk in this biological, psychological, social, cultural, political framework. Biologically, what's coming that excites me the most are actually vaccines. So there are vaccines in development. The longest kind of research effort that has been going on is with cocaine, also coming for other stimulants, but trying to see if we can develop antibodies that'll intercept the substance before it can sensitize the dopamine system.
Wow. That
Yeah,
just blew my mind. Okay.
I know. So like I'm super excited about that biologically. Psychologically, I'm super excited. There is this understanding about trauma-informed care, and more substance use disorder treatment providers are being held to being able to deliver trauma-informed care, because a lot of self-addiction treatment is traumatizing for the reasons you said, the way people get treated, stigma, no autonomy. So I'm excited about that. Social, cultural, politically, Angela, I'm really excited about this embrace of harm reduction and compassion as non-negotiables for people with addiction. So to your point, you said, I don't think when my daughter was struggling near the end there that she needed tough love. And I think you're right. When people are sick, they don't need anything tough. Mm-hmm. Like when we're sick, we need gentle. Right. And harm reduction and compassion are centered in respect and autonomy for people who use drugs, but also centered in being gentle.
It's such a hard sell for people, harm reduction. I hear all of the arguments, and how do you sell it?
Yeah, one of the ways, so when people think about harm reduction, they tend to think about it very narrow, like it's syringe exchange programs, mm-hmm. or even Narcan, overdose reversal drug, right? Those are harm reduction interventions.
Right.
But when I talk about harm reduction, it's this wider concept. So harm reduction is actually a social justice movement rooted in the rights of people who use drugs. And I love this quote by Monique Tula. She's the executive director of the Harm Reduction Coalition. And she says, harm reduction is the practice of unconditional love for people who use drugs. So yes, one way to do that is with syringe exchange, and one way to do that is with Narcan. But another way to do that is just to treat people who use drugs or people who have addiction with love and compassion. That is harm reduction. And so when I'm talking with a person who's having a hard time embracing harm reduction, like my question is in your face and provocative, but it's like, do you think that person should die because they have the disease of addiction? Now, for some people, the answer is yes. And then that's a whole different conversation. Like, yes, they should.
I was going to say, I think I've heard some of those people that would say yes.
For sure. Yeah. 100%, right? Like
it was their choice. They're a junkie. I've heard all of that, especially even when it comes to my own child. It's so hard to hear. But I don't know how you change those hearts and minds.
That is the sliver. That's the sliver.
No, you're right. You're right. It's the minority.
Country, right?
100%
the majority of people would say, no, I don't think a person should just die just because they have the disease of addiction. Okay, then you believe in harm reduction. Because that's what harm reduction is. Even though you're using drugs, I don't want you to die. I don't want you to get HIV. I don't want you to be homeless. I don't want you to be in prison.
Right.
That's what harm reduction is. So that's where I start with folks. And then it's like, okay, now we can share some statistics. We can think about what the specific interventions are. But just starting right there, you think people should die automatically just because they have the disease of addiction? You think we should let them die?
I'm going to use that in the future. Well, thank you for everything that you're doing, all the work you're doing to educate us, to help people, to change systems. You're doing it all. So I really appreciate it.
Thank you, Angela. And I want to say thank you to you too. Losing a child, sorry, I will get choked up, is I think probably one of the most devastating things that can happen, but you are saving the lives of other people's children with your advocacy. And so if there's a way to honor your daughter's life, I think that is definitely it.
Thank you. That's the way I look at it. And I still feel every day like it helps my grief to help others. I don't want another mother, father, anyone to go through what I've been through. I want to save everyone, but I can't, but I want to. And I'm just going to keep plodding away, hoping that the right people hear the message.
Yeah. Yep. It will spread. Yeah. Thanks, Angela.
Please check out the other episodes of Grieving Out Loud and read my blog on our newly designed website, emilyshope.charity. If you like what you're hearing, please consider giving us a positive review on Spotify, Apple Podcasts, or wherever you listen. Until next time, wishing you faith, hope, and courage.